Bismillah ar-Rahman ar-Rahim. It's my pleasure to be with you today and a very important week for us as a cardiologist. It is the Adult Congenital Heart Disease Awareness Week, which is started from the February 7th until February 14th. A very precious group of patients that we are taking care of them, a group of patients that who need special care and special understanding about their condition. Congenital heart disease, as you know, is a very common problem, and it is 1 in 100 estimated patient delivered with congenital heart defect in the latest publication by the American Heart Association in the state is 44,000 patients per year. With the advancement of the technique and therapy for such patient, the number of the patient grow up to adult congenital to adulthood, and they are having a congenital heart disease is increasing on yearly basis. We found as a group in Saudi Arabia that under the umbrella of the Minister of Health and the Saudi Heart Association to participate and introduce a common scenario for that we may face every day on daily practice with the stars in the field of congenital heart disease. Dr. Yasamin Hanafi, and consultant cardiologist with advanced training in adult in cardiovascular imaging and special interest in adult congenital heart disease. Dr. Ahmed Samman and Dr. Ahmed Grimley, and finally our electrophysiology. That it's a very common disease, so we have to have the electrophysiology group with us, Dr. Heshmet. From King Faisal Specialist Hospital in Riyadh. Without further detail, I would like to introduce our first speaker, Dr. Yasamin Hanafi. She will show us a very interesting case, and the title of her talk is it enough, the echocardiogram, is it enough for diagnosing congenital heart defect, or the advanced cardiovascular imaging having a major role? Dr. Yasamin Hanafi from Dalla Hospital. She will go with us live, and all is yours, Dr. Yasamin.
Thank you, Dr. Wild, for the introduction. My talk is about advanced cardiac imaging, and as Dr. Wild introduced me, I'm a consultant in advanced cardiac imaging with special training in adult congenital heart disease. Today I will present to you a case that came to me. He's a patient, 26 years old. He's a case of repaired tetralogy fellow, and he had a pulmonary valve stent for his repair, and he came on a routine cardiac MRI follow-up with annual CMR done to him every year to assess his right ventricular ejection fraction and if there is any pulmonary regurgitation after the repair tetralogy. And when we saw the patient, actually, he was quite short of breath, despite that he's 26 years old, so it was quite unusual for him. And we start scanning him with this presentation, and then we found on cardiac MRI that I will show you here, that he has quite a hugely dilated RV, which is previously known to him, but his RV function is obviously impaired, and his septum is also pushed toward the left ventricle. It means that there is some kind of pressure in addition to the dilated right ventricles. You can see in cardiac MRI here with this transaxial image, the fourth chamber view, this is the right ventricle, as I described, it's quite dilated in comparison to the left ventricle. It is poorly contracting, there is no proper contraction. And this is the two lungs, and then this is part of the lung, which shows here the bright signal is water, which indicates that he has pleural effusion. Then after that, we took further images to this patient as a routine MRI, and we found that he has also right pleural effusion that is documented completely to the right lung. We did further imaging of that patient, and this is one of his sagittal views that shows the pulmonary valve stent. And when we played the cine images for that patient, he has, as you see here, that this is the stent, that the dark area I'm describing is the stent, and the jet that that's supposed to be crossing the pulmonary valve is barely seen. This fine thread, the white signal that you can see here, is the what we suspect that we see the jet through the stent. So that was for us completely suspicious. This is the phase contracts images. And as I described here, you can see this fine jet, the bright and dark signal that crossing across, that's supposed to be the stent. And when we did a direct measurement through MRI, that's what we can do actually, like echo Doppler. We measured the velocity of that jet, and it was the Vmax was 2 meters per second. So we found that the RV is down. The RV function is quite down, and despite this function, if we expect that the right ventricular function is down, you could not see a high velocity jet, supposedly high velocity jet. So 2 meters with a combination of impaired RV, it gives you a suggestion that there is a significant stenosis across that jet. So what we have done, actually, we took that patient out to the echo Doppler. Here, a cross-section of the jet that I'm describing to you. This is the bright signal. This is the only remaining jet that we found across the pulmonary valve, and we sent the patient to urgent echo Doppler. We found that the patient has an almost occluded pulmonary valve stent with evidence of endocarditis. Patient also sent to the cath lab for urgent ballooning of the pulmonary valve, so they can relieve the valve opening, and started on an antibiotic. And retrospectively, when we reviewed this patient, we found that he has a history of fever, that he presented to the general practitioner, but they did not really properly take him as seriously as should be. And then actually retrospectively, we found that he has endocarditis. Unfortunately, this patient passed away afterward with the complication. So I will move to the next patient I have for the sake of time. He's a 15 years old patient. This patient found with ECG changes that was a T-wave inversion in the lateral leads of this patient. So he is young, 15 years old. His echocardiography was normal. There was a normal also RV ejection fraction. There was no regionality and normal index. But actually, when we did the MRI after we assessed it, we found that he has, as you see in these pictures, that he has a mid-wall fibrosis. If you look at the two-chamber view here, there is a mid-wall fibrosis anteriorly and at the apex here, and also in the infralateral wall. This is the short axis view of the left ventricle. You can see that this bright signal coming in lateral wall, inferior, and the septum. So there is quite important distribution of the ventricular fibrosis. And if we just take the case lightly, and we would say, oh, this might be a myocarditis, but I just want to remind you with a very important diagnosis with if you are screening or you are doing MRI in patient with such age, that a T-wave inversion can be a minor criteria of arrhythmogenic right ventricular cardiomyopathy. When you see the inverted T-wave is one of the minor criteria. Despite that, we found, if we look at the CMR criteria, the task force revised criteria in 2010, that if for this patient, he's supposed to have like a dilated RV or dyskinesia, but that patient did not have any of these. So he had only the ECG changes, and for the other criteria, the RV dysfunction was not present. But lately, the findings found that patient with arrhythmogenic right ventricular cardiomyopathy, 67% of those patients could have a left ventricular involvement with the presence of of left ventricular dysfunction. For that patient, he did not have that, and he can have the late gadolinium enhancement in 71% of those cases. And when they took them in this study trial to compare the dilated cardiomyopathy versus the arrhythmogenic left ventricular cardiopathy, left ventricular phenotypes, there was a statistically significant characteristic of low QRS voltages in the limb lead and T-wave inversion in nephrolateral that was the main criteria for the left ventricular involvement. For that patient, he had this criteria. And when they reviewed also the late gadolinium distribution versus the late gadolinium distribution with dilated cardiomyopathy, both of them can be inherited. They found that the late gadolinium, when it's 25% involvement of the left ventricular mass, that can be more or less of arrhythmogenic cardiomyopathy with left ventricular involvement. And if you have more than 20% of late gadolinium enhancement, that is 100% specificity for the diagnosis. So if we go back to that patient, this patient was diagnosed not myocarditis, not DCM, but he was diagnosed as arrhythmogenic cardiomyopathy, left ventricular phenotype, and we did also a genetic testing to confirm that diagnosis. Here is a paper also, the interested paper of sudden cardiac death with left ventricular involvement that I will not go into detail to it because Dr. Najmuddin, he will talk about the electrophysiology, but the presence of this left ventricular involvement can be happening in 17% of the cases, according to this study. So my take-home message that cardiac MRI is an advanced modality. It can be done as a follow-up for a patient with the congenital heart disease. It can detect endocarditis. It can also detect other cardiomyopathy that is important to be diagnosed in early adulthood. Left ventricular involvement, especially lateral wall late gadolinium, can be a form of arrhythmogenic left ventricular cardiomyopathy. And more importantly, I would love to say that cardiac MRI is a superior advanced modality, but always does not replace the clinical data. That is my end of my presentation. And for the sake of time, we're going to move to the next speaker, and we will take the discussion and questions to the end of this session. The next speaker is Dr. Najmuddin. Dr. Najmuddin is a consultant cardiologist specialized in electrophysiology. He was trained in France and also in Quebec for advanced adult congenital arrhythmogenic disease, and he's going to present also one of the interesting and common presentation of other congenital arrhythmogenic. Dr. Najmuddin, the session is yours.
Excellent. So first, I just would like to thank all my colleagues for their kind invitation to participate in this awareness meeting. So it's really my pleasure and my honor to be here and to share a discussion with you regarding this disease. I would like to show to everybody, Dr. Wael in his introduction was mentioning how huge was the improvement we did in the management of these patients. And you see here different curves, different colors. It's corresponding to different periods of time. And you can appreciate here in a green color how the survival rate improved over time, over 40 years. It's just amazing. And even in the most lethal arrhythmia, the most lethal defect we are dealing with, for example, for univentricular heart or the interrupted or hypoplastic aortic arch, still we made really a significant improvement. And again, over 40 years in this registry coming from Norway, you can appreciate how the mortality decreased significantly over time in this group of age. You can see here again, coming from the same paper, patient less than 1 year of age, their mortality was really high in the early 60s, and you can appreciate how it decreased significantly over time. but that there was a cost, there was a price to pay regarding the when they are reaching the adulthood, and you see the evolution is associated with increased morbidity and mortality, and between all these things they could present with sudden cardiac death and so on. There is a significant burden of arrhythmia. So myself, I'm a cardiac electrophysiologist, and I'm seeing these patients through the window of arrhythmias they are presenting with. And from a rhythm perspective, when we are dealing with any patient presenting with congenital heart disease, we have to manage all these situations. For the sake of time, I will not talk about bradycardia, but mainly about atrial arrhythmia, because this is the most frequent arrhythmia they are presenting with. I will say a few words regarding the anticoagulation issue. And of course, we cannot talk about congenital heart disease without talking about the risk of ventricular tachycardia and sudden cardiac death. This slide is coming from the last guidelines edited by the European Society of Cardiology. And you see here the main, in the first column here on the left hand, you can see the main diseases we are dealing with. And if we look at the burden of the arrhythmias they could present with, it's mainly this group here of atrial arrhythmia, namely intra-atrial reentrant tachycardia, but I would say most of them are presenting with atrial flutter. This is the most frequent arrhythmia they are presenting with. Again here, whatever the disease you consider, the atrial flutter is really highly frequent in this patient. And if we don't do the necessary to treat appropriately the atrial tachycardia or atrial flutter they are presenting with, then it will degenerate into atrial fibrillation, which will be really very difficult to treat. And you see here the risk of sudden death or the risk of significant ventricular tachycardia is seen mainly in tetralogy of Fallot patient or in TGA when there is atrial switch. And we continue here, the other complex diseases. Again, even for the most complex diseases, for a Fontan patient, Eisenmenger patient, you see again, the most frequent tachycardia is atrial flutter. We are seeing more and more patients presenting with a significant burden of arrhythmia in the adulthood, because these patients are living now longer. Life expectancy, as I saw in the first slide, increased significantly. Most of these patients had at least one intervention, even if not more than two, at least. And these interventions, mainly cardiac surgery, will leave them with significant atrial scars, which will participate to generate this atrial arrhythmias. So the clinical presentation of the atrial arrhythmia, it could be either really highly symptomatic episodes, or from time to time they are not feeling the arrhythmia itself, but they could present with a significant clinical deterioration, and at the time of admission, we will be discovering that they are presenting with atrial arrhythmia. Atrial arrhythmias are the most frequent cause of hospitalization, and this is the first leading cause of morbidity. What is the lifetime cumulative incidence of atrial arrhythmia? If you consider all congenital heart disease we are dealing with, the incidence is at least 20%, and it could go up to more than 50% in atrial switch patients who are presenting with TGA. And we can understand easily what is the reason here, because there is a lot of suturing in both atria, generating scars and then favoring the occurrence of atrial tachycardia. And if you look at the age here, around the age of 50, maybe more than 50% of them will present with atrial arrhythmia. Look here in this study, multicentric study. So huge number of patients, adult patients presenting with a congenital heart disease, almost 40,000 patients. 6,000 almost of them presented with atrial arrhythmia. So in this paper, they just try to compare between patients who presented with atrial arrhythmia versus those who not present with atrial arrhythmia regarding the outcome. And we can see here the outcome is really very bad. If we consider any adverse event, the hazard ratio is 2.5. The mortality is quite increased by 1.5, and the morbidity is significant with increased risk of stroke and increased risk of heart failure. And again, you can appreciate here how prevalent is the arrhythmia in all these diseases we are seeing in our daily clinical practice. For any patient to present with arrhythmia, we need a substrate, we need a trigger, which is usually atrial extrabeat or ventricular extrabeat, but still we need the autonomic nervous system. And then if you have this trait here, the patient might present with arrhythmia. But the mechanism, the arrhythmia mechanism in adult congenital presenting with heart disease is mainly because of the substrate, and we can understand the reason, because there is anatomic defect related to their disease, surgical repair, leaving them with the significant scars within the atrium or within the ventricle, diseased muscle, so the electrical system is not circulating normally, severely enlarged atrium and so on. Atrial flutter, regarding the atrial flutter, in adult congenital heart disease, we have really a perfect cocktail favoring the occurrence of atrial flutter, because again, we have the substrate, we have the triggers, and we have to know that if they are presenting with significant bradycardia, which is most of the time related to sinus node dysfunction, this is triggering atrial arrhythmia, plus the scars, plus the anatomical barriers. All these three elements will favor the occurrence of this tachycardia with a continuous atrial activity. And you see 50% in more than 50% in patient presenting with complex heart disease will present with atrial arrhythmia versus 17% in simple disease. And the atrial flutter here in orange is occurring mainly in complex congenital heart disease at younger age, and clinical presentation paroxysmal atrial flutter. So atrial flutter is again associated with younger age, complex congenital heart disease, and frequently it is a paroxysmal arrhythmia. You can see here the morbidity of these arrhythmia. 25% of the emergency admission for congenital heart disease is related to atrial arrhythmia, and you have here the distribution of the atrial arrhythmia, of the arrhythmias they could present with, and you can see here that atrial flutter is representing something like 30%, atrial fibrillation 14%, ventricular tachycardia, monomorphic ventricular tachycardia, paroxysmal monomorphic ventricular tachycardia in 9%. And if you look at this group here, which is labeled tachyarrhythmia unspecified, 43%, we do think now that still this group is belonging to the group of atrial flutter. It's misdiagnosed because of the atypical presentation of atrial flutter, and I will show you some examples regarding this issue. Regarding the morbidity, twofold increase in risk of death, we can see it here clearly, fourfold increase of risk of the risk of heart failure, and it is really significant. And there is no difference in terms of stroke. However, the stroke risk will be increased after conversion of new onset atrial arrhythmia. And this is one of the most important message through this lecture. Never try to cardiovert patient either pharmacologically or by electrical cardioversion without a TEE guidance. It should be TEE guided, and for sure these patients need to be anticoagulated. So the atrial arrhythmia they are presenting with should be aggressively managed. Otherwise, they might present with a more severe arrhythmia, which is atrial fibrillation, and it will be really very difficult to manage. One of the atypical aspects of atrial fibrillator is that the atrial rate is slower than the acquired heart disease. Usually, the atrial rate in acquired heart disease is around 300 beats per minute, but in adult with congenital heart disease, the atrial rate is not exceeding 200, maybe 230, 240, not more than that. And when it's like this, it's favoring one-to-one conduction in young patients, generated a really compromise in the hemodynamic situation. Look, for example, this patient here, he was brought to the cath lab because he was presenting with paroxysmal SVT. Then this is what we induced in the cath lab. And the first look at this tracing is highly suggestive of ventricular tachycardia since the QRS are wide. However, when we insert a catheter inside the coronary sinus or to explore the atrium, it turned out to be clearly atrial fibrillator. And if you look at the reason I'm showing this tracing, if you look here to the arterial line, immediately when we induce this tachycardia, it's only atrial fibrillator, but with one-to-one conduction, the blood pressure dropped significantly here. And it's telling us that even if they are presenting only with atrial arrhythmia, they are at high risk to present of sudden cardiac death. So again, these atrial arrhythmia they are presenting with should be managed aggressively. So this is one of the tracing which could be, this is a young patient, 20 years old female, presenting with palpitation. Previously, we know that she had ESD and VSD repair, and she was complaining of palpitation, and this tracing was considered as a sinus tachycardia. And indeed, you can appreciate here the presence of the P wave with a long PR interval all the time here. In different regions, you can see the P wave, and she was considered for a while as having only sinus tachycardia until we did a carotid sinus massage here, and we discover indeed that this patient is presenting with atrial fibrillator. So again, keep in mind that these patients, they are not presenting with the typical aspect of atrial fibrillator. And for sure, you will see this aspect at least one time, and we should do vagal, the threshold to do the vagal maneuvers should be very low in these patients, but because frequently we are discovering that they are presenting with atrial fibrillator. Those patients, usually they are bradycardic. So when they start presenting with any heart rate around 100, 110, 120, it's impossible for them to present with sinus tachycardia. Most of the time they are presenting with atrial fibrillator, but still we need to demonstrate this. This is another example here in a young patient, again, only with simple congenital heart disease. It was ASD ostium secundum, which was closed surgically, and she was complaining of dyspnea and palpitation. And again, this tracing was considered as a sinus rhythm. We can appreciate here the P wave conducted with a long PR interval. And for a while, she was considered as a sinus with a first-degree AV block until we gave her adenosine, and you can appreciate that she was presenting indeed with atrial fibrillator conducted 2-to-1. So this is the reason why, remember, this group of unspecified tachyarrhythmia, maybe it was related to atrial fibrillator. So most likely in 75% of cases, they are presenting with atrial fibrillator. So how should we manage these arrhythmias they are presenting with? If we are counting only on cardioversion, it's not working. For sure, the acute phase, we will convert the patient, but few months later, he will present with recurrency, and we have to do, again, electrical cardioversion. So better to think about something else. Rate control versus rhythm control, we don't have trials like for acquired heart disease. What I can tell you is that when they are presenting with atrial fibrillation, the heart rate is much easier to be controlled. But when they are presenting with atrial flutter or atrial tachycardia, this is a circuit and it's impossible to interrupt the circuit. It's really very difficult to slow down the heart rate. I will squeeze this slide. So regarding the rhythm control, what do we have? We have antiarrhythmic drugs. Most of the time, class 1C, flecainide, propafenone are contraindicated in these patients. So we are left mainly with sotalol, but still we need to reach a really high dose to be efficient. But if we are reaching really very high dose, we will be facing a QT problem and other adverse effects. Amiodarone is efficient, but it should be limited to short-term use in young patients to avoid exposing them to the significant adverse effects of this drug. Regarding rate control, we have to use beta blocker, but we should not forget this possibility of permanent pacing plus AV node ablation before they deteriorate significantly their ventricle. Catheter ablation is really the best option, and currently, according to the European guidelines just published in 2020, it should be even first-line option. However, it is highly recommended that it should be done with a dedicated multidisciplinary team, because we need the help coming from the specialist of advanced imaging. We need the interventional cardiologist. We need the surgeon to see where are we going with our catheter, because these patients are presenting with baffles, with patches, with different conduits, with prosthesis. So we need to have a clear knowledge of the anatomy before inserting the catheter in such patients. With this, the success rate of ablation is really quite good, at least in the acute phase, reaching almost 90% regarding the atrial flutter. However, the recurrence rate is high, not because of recurrence of the same arrhythmia. As I told you, they are presenting with different scars within the atrium, and each scar will generate its proper tachycardia. So we will be ablating the first flutter here, and later on, they will present with another atrial tachycardia. Another chapter, which is, it will be really very quick, which is ventricular tachycardia, 30-fold greater in patients with congenital heart disease, the risk to develop a ventricular tachycardia, and then a sudden cardiac death. So this is the major cause of mortality. It's related either to scars within the ventricle or to the systemic RV failure. It's not rare that in some diseases that the systemic ventricle is the RV, which will be facing a high pressure, and it will fail over time. We are considering usually only the ejection fraction for the LV, but what about the RV ejection fraction? If it is less than 35%, it is associated with a high risk to present with ventricular tachycardia and a high risk of sudden death. So we have really to pay attention in those patients when they start to present with systemic RV failure, and we have evidence coming from different papers now, and it is well known. Now we have to measure appropriately the RV ejection fraction. Scar-related ventricular tachycardia is seen mainly in tetralogy of Fallot patient, because they will have surgery earlier in their life, and this surgery here will left them again with scars, and we have several isthmus. We have to deal with this isthmus to prevent the occurrence of ventricular tachycardia. Now, a tough patient who present with a ventricular tachycardia or resuscitated cardiac arrest, we will be dealing with secondary prevention. The indication of ICD is there. There is no discussion about it. Again, we are dealing with secondary prevention. So we'll be implanting ICD. Now, as for primary prevention, we have to consider these parameters, ECG parameters, surgery parameters, cardiac MRI parameters, and echocardiographic parameters. We have a lot of factors which were demonstrated to be predictors of sudden cardiac death, but mainly we should focus on QRS duration. Usually they are presenting with right bundle branch block. If the duration of the QRS is exceeding 180 milliseconds, then they are really considered at high risk of a sudden cardiac death, and mainly when it is associated with LV dysfunction. We have to treat them with beta blocker. Ablation could be considered because the region to ablate is really very, very small, and ICD might be indicated in those patients. I arrived to my last part of the presentation, which is anticoagulation. And you see here, a simple congenital heart disease like ESD is associated with a really increased mortality. In this study, with a follow-up over 30 years, 22% of patients present with late death because of stroke, and all of them were presenting with atrial fibrillation and atrial flutter. And again, I'm insisting a lot on anticoagulating these patients when they start presenting with arrhythmia. And Fontan patients, they have a trend to present with thrombus. They should be anticoagulated. I will squeeze this slide. I arrive to my conclusion. So again, atrial flutters are the most common arrhythmia in adult congenital heart disease. They are not always presenting with faster heart rate. It is associated with a significant mortality and significant morbidity. Aggressive management should be the rule in these patients, with early anticoagulation to avoid stroke. Think about sotalol in these patients. Amiodarone should not be used at first-line treatment. Ablation is excellent option in this patient. For tetralogy of Fallot patient, don't forget to measure the QRS duration. When it's more than 180 associated with LV dysfunction, they are at increased risk of sudden death. So we can discuss ICD as for primary prevention. However, ablation could be an excellent option in young patients to avoid ICD. And with this, lifelong arrhythmia follow-up is highly recommended in these patients, and it should be integrated in a multidisciplinary management. Thank you very much for your attention. And with this, I will conclude here, and I will introduce the next speaker, Dr. Ahmed Zaman, who is a consultant cardiologist and particularly specialized in advanced cardiac imaging. So Dr. Ahmed, the floor is yours.
Thank you very much. Excellent presentation. So good evening, everybody, Mr. Chairman, my colleagues. I'm happy to present the major complex congenital heart disease in patients, especially during this happy week, the week of awareness in congenital heart disease. First of all, I would like to thank the Saudi Heart Association and the Saudi Heart Center for the invitation and for the engagement into this awareness week. So I included some slides regarding the major complex congenital heart disease we encountered during our experience, and I'm going to talk about the prevalence in some of the slides and what good news we have for patients with adult congenital heart disease. Then we're going to talk about the different congenital heart disease severity according to the anatomical and physiological classifications, particularly talking about Fontan's, Eisenmenger's, and Down syndrome. Then I have some slides to concentrate on the risk stratifications of patients with COVID-19 and adult congenital heart disease. So one important piece of information and practice in patients with congenital heart disease are the continuity of care. Regarding the prevalence, if you look at the literature, most of the prevalence in kids at birth is around 8 per 1,000. And given that the advanced in surgical techniques, advanced intervention, and sophisticated imaging in early diagnosis and management of kids with congenital heart disease, 90% of them, they reach adulthood. So the prevalence of patients with adult congenital heart disease in North America is around 3 per 1,000. So if you look at populations like Saudi Arabia, where we have 30 million, so putting this number of prevalence, ending by having thousands of patients survived adulthood with congenital heart disease. So it's a large number of patients. They deserve acknowledgement, they deserve care and management lifelong. So that's the good news. Unfortunately, those patients need lifelong care from their infancy to their adulthood and even during elderly. An example of that is patients with Fontan syndrome. These are some websites for who are interested patients, families, or residents who would like to learn more about congenital heart disease. It's on the website, and especially the International Society of Adult Congenital Heart Disease. Now, in these slides, I'm going to share some of my patients who've been encountered over the last 6 months. Like the first patient here is a young Down syndrome who is known with Eisenmenger physiology, unrepaired VSD, and came in with brain abscess. COVID was then, it was negative, so he required resection of the abscess, has prolonged course in ICU, and then he recovered and discharged home. Another fascinating complex case seen 3 months ago is another case of female who is young, show up in the emergency room with heart failure, pneumonia. Echo then, it was not clear to diagnose the anatomy, but CT was done for a PE study, diagnosed tricuspid atresia, Fontan repair, and she was COVID positive, so she was treated for heart failure, pneumonia, and SVT. So this is one of the or two of the most complex cases I have encountered over the last 3 months. Again, this is a list of 20 cases we have been seeing in the Department of Cardiology over the period of follow-up of patients in emergency room and in the clinic. And if we look here, the important highlight in red, see how much comorbidities these patients might have. Some of them presented with symptoms and signs of heart disease, pneumonia, hypothyroidism, metabolic problems, RV failures, uncontrolled hypertension and coarctations, SVTs. Some of them show up for clearance to surgery before orthopedic or ENT surgery, so they are picked up incidentally. Patients with severe pulmonary hypertension and ASDs, again, they suffer from heart failures. We have 3 patients who were pregnant with high risk pregnancy who were followed up and have a very good outcome after delivery. So those patients, they live with lifelong problems and complications. So how we deal, what is the important steps we did for our patients? First of all, we have important guidelines. We have the European, the American guidelines, which we can tailor it to our community. It's very helpful. First of all, we should know the classification of the disease. Is it mild, moderate, or severe? And what's the complexity of the disease? Is it simple disease, moderate, or complex? An example of a simple congenital heart disease is atrial septal defect, or VSD. Those can be managed, and later on in life, if they have device closure, their risk of adverse events would be lower than patients with Fontan repair who might have repeated episodes of heart failure and arrhythmias, as mentioned in the previous slides. So in the next slides, I'm going to talk about a new era of an important infection affect our patients in adulthood and in childhood. So coronavirus pandemic was started in 2019, and if you look at the literature, there are many established guidelines for the management of congenital heart disease in adult congenital heart disease, COVID-19 in adult congenital heart disease. This table showed how to look at the risk factors, combining the classical anatomical and physiological factors from stage A to stage D in comparison to anatomical, to look at the risk parameters for risk stratification in patients with COVID-19 and congenital heart disease. So stage A, patients who have no hemodynamic problems, good exercise tolerance, and no renal or pulmonary problem. versus stage D, where you have advanced heart failure, severe arrhythmia, valvular problems, pulmonary arterial hypertension, cyanosis, and refractory end organ damage like renal or heart failure. So this is a new modality looking at classification and risk stratification of patients with adult congenital heart disease. This study actually is published last year in JACC. It's a multi-center study in COVID infection in adult congenital patients, multi-center, including centers from Prince Sultan Cardiac Center in Riyadh, where they included around 1,000 patients with adult congenital heart disease who had acquired COVID-19 infection proven by PCR. And they classify patients according to stages and according to the functional stages and physiological stages. And we came up with a risk score based on adult congenital specific risk factors like cyanosis, prior heart failure, use of supplemental oxygen for cyanosis, and pulmonary arterial hypertension prior to having COVID infection. And if you look at the other non-adult congenital risk factors like aging, chronic kidney disease, diabetes, chronic kidney disease, and special heart conditions like heart failures and cardiomyopathy all contribute to major adverse events in patients with COVID disease and congenital heart disease. So you have to put together the congenital heart disease risk factors and non-congenital heart disease risk factors like aging, diabetes, hypertension, chronic kidney disease, which give you a good risk module in patients who might suffer adverse events from COVID-19 pneumonia. That question was raised in North American and UK studies and even in at the national level to prioritize patients for vaccinations for COVID-19. So patients, for example, who has an ASD with multiple valvular problems and heart failure, they might benefit earlier from the vaccination than Fontan patients who have a good hemodynamic parameters. All need vaccinations, but the priority would be for patients with a more functional and physiological disturbance. So in the next slide, I'm going to talk about the non-cardiac comorbidities in patients with congenital heart disease. Many systems can be involved, especially the endocrine and renal system. 40% of patients with adult congenital heart disease might have metabolic and renal electrolyte problems and metabolic problems. If we take an example, Down syndrome might have VSDs or AV septal defect, PDAs, or they might have AV septal defect. They might be repaired or not. Look at the prevalence of diabetes, 3 to 10 folds increase of diabetes in patients with Down syndrome, obesity, hypo or hyperthyroidism, osteoporosis. All this increase the risk of impaired immunity and opportunistic infections, bacterial or viral. This actual slide is from a UK survey study in patients with Down syndrome and COVID-19 pneumonia. They looked at the major predictors of adverse worse prognosis, which is listed as age, more than 40, obesity, dementia, males more than females, and the congenital heart disease and Down syndrome, either repaired or not. And actually, they illustrated the risk of death in patients with COVID pneumonia and Down syndrome. If they are more than 40, the risk is around 45%. And if they compare it with the normal populations, it's equal to the risk of patients who is more than 80 years of age. So Down syndrome with COVID pneumonia, elderly or older than 40 years of age, they have high risk of worse prognosis in COVID pneumonia than younger patients. Liver disease, again, one of the major parameters we look for in follow-up of patients with adult congenital heart disease, especially Fontan's or Epstein's with severe tricuspid regurg, where they might have liver problems and congestion. Infective endocarditis is the rare complications of patients with adult congenital heart disease in comparison to the general populations, but it's a risk which mandate giving prophylactic antibiotics before prophylactic antibiotics before dental procedures. The European guidelines included patients who require antibiotic prophylaxis before any dental procedure if they have 3 parameters: patients with previous infective endocarditis, patients with prosthetic valve, or patient with cyanotic heart disease. Still, the major high-risk group who require antibiotic prophylaxis. As an expert congenital heart disease team, they are aware about the advanced heart failure, PLE, protein-losing enteropathy in patients with Fontanes. 15% might progress to advanced heart failure and protein-losing enteropathy because of chronic venous hypertension, low cardiac output, and increased mesenteric vascular resistance, which can cause loss of albumin and reduce the immunity and causing venous congestion, and patients might reach advanced heart failure, which require heart transplant. Multiple modalities of treatment have illustrated here, but if it failed, patients might be listed for heart transplant. Again, Eisenmenger is one of the major end-stage problems for patients with advanced congenital heart disease without repair, like VSDs. Eisenmenger, they are prone to have cardiac and non-cardiac complications. Most common cardiac complications, as mentioned before, is arrhythmia, especially in VSDs, Eisenmenger, and single ventricles, heart failures, right and left heart failures. Most of the non-cardiac complications are bleeding, thrombosis, pulmonary embolism, renal dysfunction, and hyperviscosity, causing headache and require fluid replacement. Others, like infections, hyperuricemia, are considered another metabolic complications of Eisenmenger syndrome. Recently, this article published by the group from UK, and actually they illustrated an important approach for patients with adult congenital heart disease, education at all stages for the families, parents, pregnant ladies, engagements of adults into healthy lifestyle, exercise, normal healthy diet is very important. Engagement into the management strategies for surgery and pregnant ladies for management of major congenital heart disease during pregnancy. Even in elderly, engagement and education and empowerment is very important, especially for prevention of major risk factors, which is mentioned before, like the non-adult congenital risk factors, diabetes, hypertension. So patients, they survive adulthood, and elderly, they have start to have acquired risk factors which prone them to more problems like acquired heart disease, coronary disease, and heart failures. So I think we should adopt this strategy of education, engagement, and empowerment in management of patients with congenital heart disease. So this is my summary slides. We have to look for the anatomical and physiological characteristics of patients with congenital heart disease. Physiological staging will give more risk module stratifications for patients rather than anatomical classifications. We have to consider the non-adult congenital risk factors like diabetes, hypertension, obesity, and chronic kidney disease. Regarding patients with COVID-19 and congenital heart disease, we have to look at the major risk predictors like cyanosis, pulmonary arterial hypertension, and heart failure patients who are at high risk, especially if patients seen in the clinic and there is reluctance of taking the vaccines. Those patients with heart failure and cyanosis are at high risk for COVID infections, so they are recommended to take vaccinations, in addition to previous vaccinations like H influenza and pneumococcal vaccines. Again, Eisenmengers and Fontanes might have multi-system disease and should be investigated thoroughly, screened for heart failure and arrhythmias, and managed early. And we should have very prompt investigations for Fontanes with liver disease to avoid major complications in the futures. So always prevention better than management. In this slide, I just summarized all the major interventions regarding the approach to the comorbidities, the major comorbidities in patients with congenital heart disease, 2 major end-stage patients like Fontanes and Eisenmingers and the complications, infective endocarditis are important, prophylaxis before dental procedures, and finally, the risk stratifications in COVID patients. It's an important poster. I would add it to the slides for who is interested in dealing with follow-up and management of patients with congenital heart disease. Thank you very much. And I would like to, if you can submit your questions so we can answer it at the end of the presentations. For the next presentation would be Dr. Ahmed Kremli. He's an expert adult congenital heart disease with expertise in cardio-obstetric specialty. He's going to talk about the major advances in management of patients with congenital heart disease and pregnancy. Dr. Ahmed, the floor is yours.
Thank you very much, Dr. Ahmed, and thank you for the organizing committee to organize such a wonderful awareness days, and Saudi Heart for arranging again, supervising this program. Slide clear for you or not?
Yes, we can see the slide. Yes, we can see.
So basically, the sum up of my talk, it will be about the patients with adult congenital heart disease and pregnancy, and can they survive pregnancy. So as the facts, cardiac illnesses complicate up to 4% of pregnancies in Western countries. And maternal cardiac disease is a major cause of non-obstetric maternal morbidity and mortality, and up to 1% pregnancy has some form of congenital heart disease, and less than that acquired heart disease. But obviously, the number are getting larger and larger. And if you're looking at this survey or in maternal mortality in the UK and last decades, you will notice that the cardiac disease was the #1 cause for non-obstetric reason for patients to die. And most cardiac deaths were related to arrhythmic death and dissection, cardiomyopathy, and myocardial infarction. And however, if you noticed any cardiac through the years, if you take through the follow-up the patients with congenital heart disease and pregnancy, through the years there was some changes because of awareness, because of preventive programs, because of terminating pregnancy or advising patients to get pregnant and if their condition does not allow them. And you can appreciate that, however, despite all of this, any cardiac events between the last decades and the more recent decade is no difference. Maybe a little bit we are better in managing and having preventing pulmonary edema, but again, the arrhythmia and the maternal cardiac death is not a big difference. So if we talk about what type of heart disease in pregnant women we are facing, it's obviously depends on the region. We're focusing here about congenital heart disease, which again, across all regions, it's either the majority of patients or a big chunk of patients with heart disease and pregnancy. So if in Canada, for example, 77% of the patients with heart disease, they have underlying congenital heart disease. In RUBAC registry, which is an international registry, including Europe, Africa, and Asia, it's about 66% congenital heart disease. In Brazil, it's 19%, and in China, it's about 30%. So this is to tell you that patients with congenital heart disease, they are getting pregnant, and you're going to face during pregnancy, you're going to face them, and as usual, the obstetric will ask you, what should we do with them? So this is a case regarding a 23-year-old lady who referred because of an ASD at the gestational age of, discovered at the gestational age of 18 weeks. This is her 4th pregnancy. And the first pregnancy ended up with abortion because of abnormal ovulation. Second pregnancy ended with spontaneous vaginal delivery, and the baby died because of polycystic kidney disease. And the 3rd pregnancy was ectopic. So this is very precious pregnancy for the lady. She's known to have ASD and referred to you at 18 weeks of gestation. So after her last pregnancy, she developed shortness of breath and was referred to private cardiologist, where she was diagnosed with an ASD. And as I mentioned, eventually when she became pregnant, she was referred for our center for follow-up. She has long-standing shortness of breath with mild exertion in NYHA class 2, associated with orthopnea. There is no history of being D or chest pain, and the symptoms of shortness of breath get worse during pregnancy. She has been noticing daily and frequent palpitation for quite a long time, and there is no history of syncope. Physical exam showed oxygen saturation on room air of 99%. DVP was elevated, but this could be related to pregnancy. Right parasternal heave, normal first heart sound with fixed split second heart sound, and injection systolic murmur at the base of the heart, no lower limb edema, and clear lung exam. ECG showed normal sinus rhythm and RSR pattern. This is an echo. So you can appreciate the normal left ventricular size. However, you can appreciate the large right ventricular body. And this is again to show you the function of the left ventricle is normal, but the RV is dilated. And this is to show you the presence of the ASD. Her RVSP was normal. So the question now, what is the risk associated with pregnancy? What is her maternal morbidity and what is her maternal mortality? So we're taking this as an example, but this is usually our approach for any congenital patients throughout her pregnancy, either even before, during, or after pregnancy. So how common is a problem? So it's been estimated that annual deliveries for women with congenital heart disease increased by 35% from 1998 to 2007, compared with just an increase of 21% in general population. This is a US data. And again, if you can see in the nationwide inpatient samples, the largest all-payer nationally representative hospital discharge database in the USA, showing that there is a remarkable increase in pregnancy in patients with congenital heart disease compared with normal general population with no congenital heart abnormalities. So what does the guidelines tell us? So the guidelines for patients known to have cardiac illness or suspected cardiac illness, they should have or should undergo pre-pregnancy risk assessment and counseling. And it's recommended to perform risk assessment in all women with cardiac disease of childbearing age before and after conception using the modified WHO classification. So I showed you a case of an ASD, which is considered among advanced congenital heart disease as a simple ASD congenital heart disease. She's not complicated Fontan, for example. She's not mustard. She has no coarctation, and definitely she's not Epstein anomaly, etc. So, but her case is simple. So Dr. Ahmed Samman mentioned the congenital heart disease anatomy and physiology staging, which is basically the recommended classification by the American guidelines. And it basically classifies the cases into simple, anatomically, it's into simple, moderate complexity, repaired or unrepaired, and great complexity or complex. And then adding on that the physiological classification, because, for example, you may have ASD patients doing fine, enjoying her life, and you may have ASD patient with pulmonary hypertension or Eisenmenger syndrome. So anatomically they are the same almost, but physiologically they are different. So our patient is almost a class 1 anatomically, simple lesion. However, she is in NYHA class, function class 2, or 2 to 3 actually, because of her pregnancy. So anatomically she is 1 to 2. Physiologically she is at stage B. And all women with other congenital heart disease, anatomical physiological classification 2B, and should be managed collaboratively during pregnancy by adult congenital heart disease cardiologist, obstetrician, and anesthesiologist experienced in adult congenital heart disease. So that just So the guidelines is telling us that ASD, even simple ASD patients, should be managed by experienced group dealing with congenital heart disease. So let's start by the end and ask, how does pregnancy end in patients with congenital heart disease? So majority, and this is our job, to end up pregnancy completed in a good outcome. The baby is healthy and the mother is healthy. However, minority of patients will end up having elective abortion after counseling, and depending on the underlying diagnosis, some patients up to 40% may have miscarriages during pregnancy. So, for example, Fontan patient, up to 40% of Fontan patient, their pregnancy will end up in miscarriages, and this is again cyanotic patients. So what are the risks? So the risk, the maternal and fetal risk are higher in patients with congenital heart disease compared to normal population. However, the good news is maternal deaths are rare. When we talk about risk, cardiac risk for such patients, usually we are worried about development of heart failure, development of arrhythmia, development of stroke, infective endocarditis, and death. And this is to show you that what are the complications for pregnancy in women with congenital heart disease. And the mother complication, usually arrhythmia, heart failure, or cardiovascular events. And you can appreciate, depending on the diagnosis, one complication will prevail against others. For example, in patients with Troji fellow, they will have more arrhythmia during pregnancy complications than heart failure. But if you're looking at pulmonary atresia patient with VSD, they will have their pregnancy will be complicated by heart failure more than arrhythmia, etc. The fetal complication, the most common fetal complication for patients with congenital heart disease are preterm delivery, small for gestational age, and death, obviously. So this is a ROBAC registry, which I just talked about, which is a registry of pregnancy and cardiac disease. It's based in Netherlands, Europe, but include countries from Asia, Africa, and Europe. Saudi Arabia is not included or did not include patients, but we have Egypt, and we have United Arab Emirates. And it tells us what is the outcome in general for patients, pregnant patients with heart illness. And if you can look into maternal mortality, so it's very low. It's very low. However, congenital heart disease, they have better mortality than patients with valvular heart disease, mitral stenosis, bicuspid aortic valve, compared to cardiomyopathy. And so the bottom line, mortality is presence. Congenital heart disease are not spared from having mortality during pregnancy, but it's better than other diagnoses, especially cardiomyopathy. And once patient has congenital heart disease, the outcome for complexity and odds outcome is much, much higher than patient with no congenital heart disease. So how do we usually evaluate such patients? So as Dr. Samman mentioned, you have to have an excellent understanding of the patient's anatomy and physiology. But the key, I think, which we usually spend time trying to liberate from the patient is maternal functional status, because it's as simple as this. If the patient is doing well prior to pregnancy, there is a big chance the patient will end up her pregnancy doing well. However, if the patient is not doing well prior to her pregnancy, definitely the pregnancy will be at high risk for complications, and the chance for having a complication or end up pregnancy in a not nice way is quite high. We have a special risk scores. I will go through them quickly. Scoring system for to risk stratify the patients with congenital heart disease who wants to get pregnant. And as I mentioned, the European recommends a modified WHO. And then we can talk about lesion-specific risk, like, for example, patient with ASD, what are the special risks for them? Patient with Fontan, what are the special risks for them, etc. So this is a very common question. Does exercise test prior to pregnancy has any role? It does in some patients. So exercise test can be useful for risk assessment in women with with other congenital heart disease, anatomical physiological classification, special. So not all of patients, but the special patients who wants to get pregnant, they may exercise testing can be considered. And why is that important? Because pregnancy considers a stress test for life. And you'd like to be sure in borderline cases that the patient will tolerate pregnancy and will not have adverse events during pregnancy. Because not even if the patient survives the pregnancy, that's a good news only. Even if the patient developed complication during pregnancy and it was managed well and her pregnancy ended nicely, she's still the patient at risk of developing poor cardiac outcome compared to patients who did not develop adverse outcome during pregnancy. So just the fact that having a adverse maternal cardiac events during pregnancy will carry a risk for even up to 5 years, will carry a risk compared to patients who had a pregnancy with no cardiac events, even after successfully ending the pregnancy. So as I mentioned, in general, we talk about lesion-specific risk, and usually the mothers will ask, what are the chance for complications? What are the possible cardiac complications? For example, in unrepaired ASD, we are looking for, or we are worried about atrial arrhythmia, thromboembolic events more than heart failure. What about the obstetric complication? Usually we're worried about prematurity or small for gestational age. And then it comes a question regarding transmission. What is the chance for transmission? And in general, it ranges between 3 to 8% chance of transmission. For example, ASD, there is a chance of 5% chance of transmitting the congenital abnormalities to the offspring. So every patient is unique, and risk assessment should be based on patient underlying condition, function status, previous operation, intervention, history of complications, and outcome of previous pregnancy. We want to have a standardized tool for estimating the risk of serious complication during pregnancy. And for that, we have multiple risk scores. So we have CARPREG-1, we have CARPREG-2, we have Zahara, and we have modified WHO. I won't concentrate on CARPREG-1 or Zahara because the guidelines, although it's acknowledge their presence and their importance, but it's not highly recommended. And the guidelines, European guidelines, recommending using the modified WHO classification for scores. There is, after the guidelines published, there is a CARPREG-2, and it's a very good risk scoring assessment, and I believe it will be included in future assessment. So risk assessment, and so it's again, as I'm saying, the guidelines, 2018 European guidelines for other congenital heart disease, enforcing the modified WHO classification for maternal risk. And it's been recommended to perform risk assessment in all women with cardiac disease of childbearing age and before conception using the modified WHO classification. So this is a CARPREG score, which is very easy, for 1 point up to 4, and it's a very good risk predictors. However, as I'm saying, it has its shortcomings. And this is Zahara. Again, it's a very good scoring system, but again, both they have their downsides, and that's why it's not highly recommended in the guidelines. So these are the modified WHO, and it classifies patients according to their underlying anatomy or non-diagnosis. So, for example, modified WHO1 includes small or mild pulmonary stenosis, PDA, mitral valve prolapse, or successfully repaired simple lesions such as ASD, VSD. So, and modified WHO class 2, it's unoperated and atrial or ventricular septal defects such as our patient, or repaired atrial fellow, most cases for arrhythmia, Turner syndrome without aortic dilatation, etc. So obviously, by exercising and seeing more patients, this risk score or system will be easy to remember. But in general, just mentioning diagnosis at the moment, It will be very difficult to remember which disease goes into which classification. But so why we're doing this? Because, for example, the modified WHO1, they have no detectable increased risk of maternal mortality and no or very mild increase in risk of morbidity. And this is compared to modified WHO class 2, which carries a small increased risk of maternal mortality or moderate increase in morbidity. So the modified WHO 2 to 3 has intermediate increased risk of maternal mortality or moderate to severe increase in morbidity. The WHO class 3 has significant increased risk of maternal mortality or severe morbidity, and these patients usually we discourage them from getting pregnant. However, these are the patients, the modified WHO class 4, which suppose not to get pregnant, and if they get pregnant, they should be counseled regarding early termination, and includes pulmonary arterial hypertension of any kind. And why is that? Because they can carry an extremely high risk of maternal mortality or severe morbidity. And pregnancy is contraindicated, and if pregnancy happens, termination should be discussed. And include pulmonary arterial hypertension, severe systemic ventricular dysfunction with an ejection fraction less than 30%, previous perimortem cardiomyopathy with any residual left ventricular impairment, severe mitral stenosis, severe symptomatic aortic stenosis, systemic right ventricle with moderate or severely decreased ventricular function, severe aortic dilatation, and this is the definition of severe aortic dilatation, tetralogy of Fallot with an aortic valve, aortic root of 50 millimeters, that's a contraindication for pregnancy. Any patient with vascular Ehlers-Danlos syndrome, severe coarctation or recoarctation, spontan patient with any complication, such as PLE, etc. So what about the babies? We mentioned that majority of pregnancy will end up either by preterm delivery or small for gestational age, and this happens up to 1/3 of the patients. And mortality for the mothers are rare, but it happens for babies up to 5% in general. So how to risk estimate during pregnancy? Is there any risk estimation methods during pregnancy? Yes, there is, and usually it's a BNP. So around 20 weeks of gestation, when the cardiac output peaks during pregnancy, we usually like to draw a BNP level. And if the BNP level is more than 100, that puts the patient at the chance of either having adverse cardiac events during pregnancy or no adverse cardiac events. However, a normal BNP at peak of cardiac output hemodynamic changes during pregnancy, which is around 20-22 weeks of gestation. If its BNP is normal, that means patients will unlikely to have any adverse cardiac events during pregnancy. So this is a very reassuring methods, an easy method, just some simple blood work during pregnancy. So in summary, majority of women with heart disease may have successful pregnancy. Any woman with heart disease and in childbearing age should be counseled regarding pregnancy. Heart failure and arrhythmia are the most common complication during pregnancy. Maternal mortality is rare. Preterm delivery is the most common fetal complication. And simple lesions, such as our patients, may turn out to be very complex, and they deserve follow-up in experience center. Our patient was pregnant, and she got pregnancy, and she evaluated, and we discussed with the risk with her, and she ended up having a successful delivery with no complication, luckily. And the only patients we usually advise against pregnancy or ask for termination are the patient with WHO class 4. And this is a very nice website. I think it's a very simple website. Indicate you can just type choose a diagnosis, for example, Epstein anomaly, tetralogy of Fallot, AST, and it lists the possibility of the risk for complication during pregnancy, what to do, how to counsel patient prior to pregnancy, during pregnancy, the labor and delivery, etc. And by this, I'll end my talk, hoping that I gave an overview for heart disease and other congenital patients.
Thank you very much, Dr. Ahmed Grimley. As usual, you are star in the area of the heart disease in pregnancy. I always learn from you, and really thank you very much for this comprehensive talk. We'll try to, for the audience, we'll try of the Saudi Heart Association and Kunuz Ritaj, the company conducting this live transmission. So for everyone to enjoy this lectures. I will direct, because in the view of time, we only left about 7 minutes. I will direct a couple of questions to each of the speaker, and we'll take it from there. My first question to Dr. Yasamin. Dr. Yasamin, what's your advice for the general doctor and the general cardiologist in the community if they see a patient with right bundle branch block, with the mild RV dilatation in echo? What's your advice regarding this? Like in a way to pick up all or to diagnose all the patient with congenital heart disease. You showed us a very nice case of BS in adult. It's a rare condition, but is common in our community. What's your feedback?
Thank you for the question, actually. Well, echo is the first modality right now for any patient with cardiac disease, but we should not stop doing echocardiography. Now we have cardiac MRI. Cardiac MRI already listed as a non-invasive procedure with zero radiation, with superior acoustic window, and also functional assessment and gadolinium enhancement, which is more advanced than echocardiography. So there is no harm for the patient. And actually, the recommendation with the patient with adult congenital heart disease who underwent repairs, whether this is aortic disease or congenital heart disease, is to do cardiac MRI as a routine for follow-up. And if you find actually a new lesion or a suspected lesion, you should raise the suspicion of that lesion and ask for advanced cardiac modality. Usually cardiac CT is an anatomical approach, and probably people would prefer cardiac CT, but actually it does not give you a functional assessment like cardiac MRI. In addition to that, cardiac MRI has no radiation or zero radiation, and also there is no contrast which can be given, and is very safe for patient with at younger age. So be suspicious. Always ask for advanced modality. Patient with congenital heart disease, they should have a routine follow-up, like what Dr. Najmuddin pointed out. Patient with a repair tetralogy fellow, they might have risk of arrhythmia and VTAC in the future, and you cannot tell that unless you do cardiac MRI, where it is the only robust modality to assess the right ventricular ejection fraction by MRI. So they need the RV ejection fraction assessment. They need to risk assessment with the presence of late gadolinium. This is a simple case. If you have a arrhythmia patient with ECG abnormalities, especially at young age, cardiac MRI is the first choice to whether locate if there is a scar, if there is any other congenital anomalies, extracardiac, intracardiac shunt. RV dilatation is one of the most common example, whether you have to rule out intracardiac shunt or extracardiac shunt, and you can do it without TEE. So you can assess the ASD presence, you can see if there is sinus venosus by cardiac MRI, if you really point out the question.
Thank you very much, Dr. Yasamin. Very important that, to think about congenital heart disease. For example, right bundle branch block is very common in such group of patients. When you see right bundle branch block, symptomatic or asymptomatic, ask for echo. If you are in doubt about the diagnosis in echo, ask for transesophageal echo, ask for cardiac CT or MRI. Send the patient for the right people who know about such anatomy. My second question to Dr. Najmuddin, then I will leave the discussion to Dr. Saman and with the question of the audience. Dr. Najmuddin, as you know, in general practice, general cardiology, general doctor, the tool we have to screen patient, to diagnose patient is ECG and Holter. What is your advice to general cardiology in a simple way when they deal with a patient with a congenital heart disease presenting with palpitation? 1, 2, 3, just tell us what's your approach until they end up with you in a higher center?
Yeah, thank you. Thank you very much. This is really very great question. For the sake of time, I didn't show all my slides, but there was a slide regarding the issue of Holter when it is indicated in this patient. The efficacy of Holter, the yield of Holter regarding the diagnosis of the arrhythmia they are presenting, they could present it with, is really very, very low. So we are considering some features based on 12-lead ECG. As you mentioned, most of these patients are presenting with right bundle branch block. Let's consider, for example, the Epstein anomaly. These patients should have a right bundle branch block. Just because of the anatomy and the physiopathology, they should have. It's mandatory. Otherwise, we cannot talk about Epstein anomaly. If the right bundle branch block is not present, which is often the case in these patients, it means that they are presenting with accessory pathway. And I remember a few years back, one patient was referred to our center, and he was supposed to be ablated for an accessory pathway with a clear pre-excitation on the initial tracing. But when he came to our center, he doesn't have any, the ECG was not showing any right bundle branch block. So then we start to think about another accessory pathway, and as usual, Epstein anomaly is associated with multiple accessory pathway. And indeed, when we did the new EP study, it revealed that he was presenting with a new accessory pathway which was ablated. So I think this is really a few clues regarding Epstein anomaly, which is leading to sudden cardiac death, not because of ventricular tachycardia, but because of the atrial arrhythmia they are presenting with. So regarding the screening of these patients, again, to come back to your question, I do think that a loop recorder is really a good option for these patients if we want to catch any arrhythmia they are presenting with. So we start usually by recording 2 or 3 days Holter monitoring. If we don't catch anything, and if the patient is still complaining of palpitation, the threshold to go for a loop recorder is really very low.
Thank you,
Thank you very
Dr.
much. Dr.
Thank you very
Salman, all
much.
is yours.
Thank you, Dr. Wael. Dr. Ahmed Grimley, as an expert in pregnancy and congenital heart disease, I see 2 questions in the audience. The first one is a female who is 24 years of age, second pregnancy with severe pulmonary stenosis, and 9 months of pregnancy. So what would be your approach for this lady in her pregnancy? This is the first question. If you just open the mic, please.
So thank you for the question. So obviously, we need more information. How did her first pregnancy ended, etc. But she carried on till the 9 months, and now it's time for delivery. And I guess the question is regarding the method of delivery. So in general, for patients with adult congenital heart disease, as long as they're stable with no major risk features, like, for example, very bad LV dysfunction, very bad LV dysfunction, or ongoing active cardiac illness like heart failure or arrhythmia, usually we recommend vaginal delivery. So a vaginal delivery will be recommended in such patient with a very good pain control and for such patients. So some people will advocate for assisted second stage, but that's a very debatable. And usually I don't try to teach the obstetrician how to deal with their patients, but in general, if they can facilitate the second stage where the active labor of is happening, I'm happy with that. So then about monitoring, could be such patient be monitored or delivered in the ICU or something, or CC or something like that. In general, such patient we don't recommend. There is no need for such invasive hemodynamic monitoring in the ICU or CCU. So as long as they're stable, not in heart failure, I think usual monitoring will be enough. They are at risk of arrhythmia and right side heart failure, but that will be quite obvious when it happens. And in general, inshallah, as long as she tolerated 9 months and her previous pregnancy didn't happen any, didn't encounter any complication, most likely she will end up having good pregnancy. But the question is about third pregnancy, and this should be discussed with her. Although the risk, yes, it's so far didn't have any complications, but again, this is not a guarantee. And the third pregnancy or options for contraceptions or treatment prior to fixing the pulmonary stenosis prior to future pregnancy is extremely recommended.
Thank you, Dr. Ahmed. I think your answer is excellent. And again, we come to the notion that education and engagement and empowerment of patients with congenital heart disease, counseling before pregnancy is very important, especially you consider the third pregnancy. There's another question about the use of endocarditis prophylaxis in pregnancy for patients with congenital heart disease. I mentioned that in my slides, all patients with prosthesis should be covered with antibiotic prophylaxis. Do you have any other opinions from your experience in pregnancy? Please let us know.
So basically, no special recommendation. Still, it's not updated. It's the same. Nothing changed in the guidelines, actually.
Okay, very good. So there is a third question. I think it should be directed to the AP expert, Dr. Najmuddin. Patients having AFib before and after valve surgery usually needs anticoagulation for the rest of their life, yes or no?
Definitely yes, and I just forgot during my presentation to mention that the Schatz-Vask score we are using usually to stratify the risk of a thromboembolic event in patients presenting with AFib. We should not apply it in congenital heart disease. If they are presenting with any atrial arrhythmia, then anticoagulation is mandatory. So the answer is yes.
Very good. Thank you very much. There is no more questions from the audience. I have a quick comment and question for Dr. Wael Khashkari. Dr. Wael.
Dr. Ahmed,
yes?
just stop. There is a question actually from Dr.
Yeah, where is it? Okay.
I think
go
the
ahead,
question,
Yasemin, say the question.
the question with Dr. Najmuddin, he asked pacing in patient with complete heart block with Fontan.
Oh, this is really good question. Difficult question. Difficult to answer this question. Usually, these patients, when they need the pacemaker, I do think personally that epicardial approach is still the best approach in these patients, because as I mentioned before, they have really a huge trend to present with a clot, and if we are uncertain any lead inside the heart, it will favor further thrombus, and they will through this thrombus into the pulmonary artery. And as you know, this is a passive circulation, so it will really increase the risk of failure. So I would suggest definitely to implant epicardial leads. Otherwise, if this approach cannot be used, those patients, it's rare that they are presenting with AV block. They are presenting mainly with sinus node dysfunction. So still, but we have to know exactly the anatomy. We can implant just one lead into the atrium through the cephalic approach and program the device in AIR mode. So this is really a technical aspect. But the main message here is to avoid implanting leads inside the heart, particularly in Fontan patients. Definitely better to go for epicardial approach.
Okay. Exactly.
Sorry.
Yes. Yes, Dr.
Ahmed. In the view of time, there is a 3 question, one for you, one for Dr. Grimley, and one for Dr. Najmuddin, but we need a quick answer. Between all of us in the group, the one with the vast majority of experience in the community is you, Dr. Ahmed Samman. My question to you, why do you think there is still patient with congenital heart disease, even simple like ASD, like coarctation, we are missing in the community until they develop complication like pulmonary hypertension. What do you think the reason behind? Is it lack of knowledge, lack of like asking the proper investigation, or like just tell me from your really daily experience, what is the major issues here?
This is an excellent question, Dr. Weil, and I think this is why we make this awareness day and the awareness week. First of all, we have to remember an important step. Patients who have congenital heart disease, they have a gap. We call it failure of transition to adulthood clinic. So first of all, loss of follow-up of patients from childhood to adulthood, okay? Especially in Saudi Arabia, patients reach adulthood at the age of 14. So they lost their follow-up from pediatrics and they don't have follow-up with adults. So there should be a proper transition of cases of congenital heart disease to adults. Number two, educations. As we said, we educate, we engage, we empower. Education is very important for patients, even with simple congenital heart disease like ASDs, for two reasons. Number one, they get adulthood with more complications of arrhythmia, as Dr. Najmuddin mentioned in his slides. They are, as I mentioned in the study which was published in JACC, even if they are having some simple congenital heart disease with major heart failure or arrhythmia, they are prone to have worse outcome after COVID infection. This is a new information. We didn't know about it before, because we know that patients with Fontane's, Eisenmenger's, or complex TGA with RV failure, they are prone to have complications more. But now, given that we have COVID infection era, we learn more about those patients. Number three, having expert people and cardiologists like you and Dr. Ahmed and the rest of the interventional team doing more sessions, more educations, more awareness about the safety of the procedures of ASDs, VSDs. I think that will raise the education levels in those patients, give them more trust, more engagement, more empowerment to go into hospitals and happy to do the procedures. And I'm sure you have many patients who lost their follow-up and they show up with major complications in the future.
Thank you, Dr. Ahmed. Dr. Grimley, my question to you, it's a question came through Twitter. Patient asking, what is the, like patient, a baby born with an ASD, a small one, is it gonna grow? Is it gonna stay the same? Is it like, what is the natural history of a small ASD defect in a baby?
So it depends. However, it's like a playing with billiards, so it can close spontaneously. First of all, we have different types of ASD actually. So the most common type is secondary ASD, and these are the patients who could be discovered incidentally. A majority of patients with primary ASD patient will be sicker.
No, it's a secondary ASD, Ahmed. We are focusing on secondary ASD.
Yeah, so secondary ASD. So majority. So it's very challenging to tell the answers, but some of them will close spontaneously, some of them will not, and majority of patients will end up having a normal life without knowing that ASD, unless somebody examine him and listen to them, etc. And some may require intervention early on, either a teenager or later on in life. And rarely they may have intervention during childhood actually. For simple secondary ASD.
So the last question before we conclude is for Dr. Najmuddin. Dr. Najmuddin, a question also from Twitter. A patient with a small ASD, 5 millimeter, with no hemodynamically significant, nothing, it doesn't cause symptom or RV dilatation or anything, but the patient is having LV dysfunction and he's requiring an ICD or a pacemaker, for example. Would you advise for ASD closure before implanting your device?
I think this is really the situation we hate before implanting any device, and this is the main reason we are doing systematically a complete imaging workup to be sure that there is no shunt before inserting any device. And I think the message here is really important. If we are going to insert any device inside the heart, we have to be sure about the presence of any shunt. So if there is ESD and we have to implant a device, I would strongly suggest to do something regarding the ESD. I think we have to discuss with the interventional cardiologist, with the specialist of imaging, with everybody before taking the decision. But myself, in this situation, again, if in advance I'm aware that there is a shunt, if there is no indication to close it, then I would suggest epicardial approach is better than inserting something which will be thrombogenic, and we don't know. Today, it's really a simple procedure we are thinking about, but it might be a nightmare within few years because we don't know how will evolve this ESD.
Okay, thank you very much. So we reached at the end of our webinar today. It was very successful. We have too many audience from more than 25 countries all over the world. We are very happy. I would like, first of all, to thank the Saudi Council for Health, represented by Dr. Adel Tash, with his great support for this webinar. I would like to thank the Saudi Heart Association, represented by Dr. Walid Al Habib, for his great support. And I would like to thank Kunuz Ritaj, who organized all this meeting in perfect way. I would like to thank for sure my colleague, starting from Yasamin Hanafi for her excellent talk, Dr. Najm Ad-Din, who really enriched our meeting, and thank you for his presence, and Dr. Ahmed Samman, the doctor with the really helping the community with adult congenital heart disease, active, well known about his participation in all the meeting in the Awareness Day. And finally, to my colleague, Dr. Ahmed Grimley, the star of obstetric cardiology, very active, spreading his knowledge all over the kingdom in this matter. Thank you for our audience and for the time and being patient with us. I hope they enjoyed. We will try to, and we will post all this lecture online, and soon we will send you the link for that. And at the end also, I would like to thank myself for being here with you guys. Thank you very much.